Warm good afternoon to everyone. I will be talking on quality and outcome measures in rehabilitations. Rehabilitation medicine is concerned with restoration or improvement of human functioning. Uh, all the rehab interventions carried out by the team should result in an individual patient developing a specific ability to carry out the desired activity and resume his role in society. The effectiveness of these interventions carried out during the rehab process must be evident to patients and their caregivers, healthcare professionals, and third party assessors like accreditation bodies and insurance payer. So, there is a need of a common language which all of these stakeholders can understand. Just like all the medical specialties practice evidence based medicine, and rehab medicine being no exception, it is essential that rehab medicine should move from a client based services to evidence based medicine. For this, systematic tools for tracking progress, providing structured services, and communicating the effectiveness of treatment process are essential requirements in modern medical practice. So, what is quality in healthcare? High quality healthcare provides a range of services to meet the most important healthcare needs of population safely and effectively within local and international regulation. It is also the degree to which services for individual and population increases the likelihood of desired outcome and are consistent with current professional knowledge. So, how can we improve the quality? So, the first is to have it assessed by a third party assessors. As for India, we have National Accreditation Board for Hospitals and Healthcare Provider, that is NABH, and the patient payouts depend on whether the hospital is NABH accredited or not. And internationally, the Joint Commission International. And adherence to these standards is generally accepted as a measure of high quality healthcare. The other way is to develop key performance indicator, also known as KPIs. These key performance indicators are measures of performance based on standards derived through evidence or expert consensus. They help to monitor, evaluate, and improve performance. They act as a signpost that signal progress and indicate opportunities for further improvement. Examples of key performance indicator could be a generic such as an outpatient waiting time in a hospital, or in context of rehabilitation for a tertiary care hospital, it could be the percentage of patients of completing stroke availing rehabilitation facilities in that particular hospital. These KPI establish a baseline, help sets target to achieve, measures improvement, compare performance, and also acts as a benchmark performance against national and international norms and allow independent judgment of health system performance. So for establishment of specific KPI for rehab services, it requires input from all the stakeholders like physician, nurses, and therapists. It should also have an objective validated data should be collected, and that data should be used to focus the program. And with this data, we should take a feedback and implement and sustain changes from this data that results in further improvement. So the common KPI used in rehabilitation services are hospital associated pressure ulcer per day spent in rehabilitation. This can be used very efficiently for patients for spinal cord injury who stays in rehab facility for a duration. Also, catheter associated infection per day spent in rehabilitation, and the fall rate of patient in rehabilitation. For all of these KPIs, we have to set a target, that our target could be that we don't want any fall. So when we set that target, then we have to identify what will be our next step. So if there is a fall, we can reach a conclusion that all the transfer training could be done with the help of a harness. Now coming to outcome measures. Outcome measures are assessment that measures the change in patient functioning, performance, or participation over time. Good clinical care involves monitoring patients' outcome through appropriate use of such measures. They can be useful in informing clinical decision during treatment planning and goal setting. Outcome measures are also required because it is not possible to have high quality randomized controlled data to guide all the therapeutic decisions. In such cases, outcome measures comes as an help where you can track the improvement from a baseline following a clinical intervention. Tracking outcomes using standardized measure guide clinical decision making and justifies an intervention when trial data is unavailable. Therapeutic decision ought to be taken in context of data from high quality and from outcome measure analysis. So there are a lot of outcome measures available, and these outcome measures most of the time are developed for a particular population. So hence culture, geography and language should be considered, and when this outcome measure has to be used on another population, it should be validated before the use. So how to select a good outcome measures? First of all, it should be valid. Does it measure what it claims to measure? Means, does it answer the questions we are asking? The validity further has 3 domains, that it should have a face validity, content validity and construct validity. It should be reproducible. The results produced by an outcome measure should not have much of intra-rater and inter-rater reliability. And then it should have a scaling properties that it can produce a total score and a score for subgroups. For example, in case of FIM, we have a total score of 126, but then it has a motor subscale and cognitive subscale. It should be feasible. It should also be responsive, that it should detect change. It should be sensitive. It should not have a ceiling and a floor effect. For an outcome measure, ceiling and floor effect means for any survey, if most of the participants end up having a maximum score, so it will have a ceiling effect. There won't be much change. And on the other side, if most of the patients will end up having a lower score, it is called as a floor effect. So it should be free from a floor as well as ceiling effect. It should be interpretable and it should be engaging. The smallest change detected by an outcome measure that is not the result of measurement error is defined as minimal detectable change. How small this change detected by a rehabilitation measure outcome is clinically important is defined as minimal clinically important difference. So the outcome measure can be based on function, quality of life and cost. For function, it could be based on activities of daily living, like Barthel Index, FIM, and so on. So the most common tool used for assessment in rehabilitation are measures of activity of daily living, of which FIM is most common. FIM, as we all know, is an 18-item scale, ordinal scale, which has score from 18 to 126 for each activity, like 1 to 7, complete dependence to independence. And it also acts as a global measure of burden of care, assessing 13 motor and 5 cognitive tasks. So the FIM was used in America extensively for assessing performance outcome to calculate reimbursement. It was also found that of the 5 measures for inpatient rehabilitation facilities, the 3 were FIM based. These were namely the discharge FIM, the FIM gain, which is calculated by the FIM at discharge minus FIM at admission, and FIM efficiency, which is FIM gain divided by the length of the stay. Then comes ICF. So ICF, as we all know, looks into the personal contextual factor and environment. It is owned by WHO and is free to use. Because of its comprehensiveness and cost effectiveness, it is gaining importance. Then outcome measure based on quality of life. These can be specific or generic. The generic could be brief quality of life. Disease specific could be the like Parkinson's, incontinence impact questionnaire. Generic outcomes permit comparison in large number of conditions. They have normative data and have a ceiling effect, with not all the domains responsive to change, whereas disease specific outcome may be more relevant to the population under study but can have limited comparability and can miss broader changes. Then outcome measures could be related to cost. It could be direct, how much the cost has incurred to the health system, and indirect, how much wages were lost because of the rehabilitation. So for a particular condition, there could be competing outcomes. So the outcome used will depend on who is interested. So outcome for a particular condition may be varied and many faceted. Choosing outcome depends on what is more important to the client and what intervention is being carried out to address that particular impairment. For example, in a patient of a pain, if our target is to reduce the pain, so different people who are involved in this process will have a different perspective. For a physical therapist, he will be interested in assessing how much gain is there in strength and range. For an occupational therapist, he will be interested in that after pain reduction, how much he can adhere to ergonomic modification. For a psychologist, it will be after pain reduction, how is there any improvement in his day-to-day coping skills, and overall whether there is any improved aerobic capacity or capacity to perform tasks. Whereas for the patient concerned, the most important for him is whether he can return to work. So different persons engaged in a process have different perspective. So similarly are the outcome measures. So what the questions we should take care while determining which outcome measure to use, that what is my outcome of interest, who is going to be interested, whether it is a physician, patient or manager, whom will it be used on, who will be assessed, what are the validity and reliability, is it responsive to change, that whether it has a floor or ceiling effect, is it cost effective, or whether it is patient reported or clinically measured, and what are the statistical tool used. So it is not possible to cover all the outcome measures in detail, but still we'll go through the few of the most commonly used. So the Barthel index measures functional independence. So there are 10 activities. Score is 0 to 100. And reliability is with the help of a Cronbach alpha. Cronbach alpha value gives us internal consistency of a result. Its value could be 0 to 1, where value more than 0.7 is considered acceptable. And inter-rater and test-retest reliability, the value more than 0.8 gives a good strength. And on Barthel index, score less than 20 indicates total dependence, 20 to 60 indicates severe dependence, 61 to 90 indicates moderate dependence, and 91 to 99 indicates slight dependence. FIM we have already discussed. It also has a good reliability and validity. Now coming to balance. For balance, there is a scale called as a Berg balance scale, which has 14 parts. Each part is given a score of 4. The maximum score can be 56. And out of this 56, if for a total score of, if the score is 0 to 20, it indicates a high risk for fall. If the score is 21 to 40, it indicates a moderate risk. And for score of 41 to 56, it indicates a low risk of fall. Then for patients requiring cardiac rehab, there is a outcome measure called as Borg scale of perceived exertion. The purpose is it measures the person's perception regarding his own physical effort in an exercise or activity. It is a 15-point scale from 6 to 20 or modified 11-point scale from 0 to 10. It has a good reliability in context of dyspnea as well as fatigue. Also, it has a good validity when looked in comparison with the heart rate and VO2. It is used as an overall indicator of exercise production from the patient. Now, the most commonly used for musculoskeletal condition, numeric rating scale for pain, 0 to 10. 3-point change in score suggests a true change in pain intensity. Disability of arm, shoulder and hand, DASH. A quick version of it is Quick Dash is available. The DASH is a 13-item self-reported measure covering function, symptom and social role. Lower score reflects less disability. It also has a good reliability as well as good validity. Now time up and go. Time up and go score is used in elderly patients to look for mobility and balance. We do use this score in our patients for osteoarthritis knee. So the patient is asked to get up from a chair, walk a distance of 3 meters, come back and sit on the chair. So the time taken during this process is noted. So if the time is less than 10 seconds, the patient is considered to be independent. If he takes more than 10 seconds but less than 20 seconds, he seems to be independent only for indoor but not for outdoors. But if he takes More than 20 and less than 30 seconds, he is dependent and he requires some mobility aid. That is how you interpret. Then WOMAC is used for osteoarthritis knee, and it also has a good reliability as well as validity. Then gross motor function measure. So it is used for patients of cerebral palsy. It has two types, GMFM 88 and 68. So it has 5 subdomains such as rolling, crawling, sitting, standing, and ambulation. So it is found to have a good reliability as well as validity. It validates number of rehabilitation interventions, physical therapy, electrical stimulation, and surgical intervention. So even though for most of the purposes, even now, even for disability certification, we are using gross motor functional classification, which gives us 5 levels, that is level 1, 2, 3, 4, 5, where level 1 and 2 are independent ambulator, level 3 requires assistive devices, level 4 and 5 requires wheeled mobility. But GMFCS is not sensitive to change. This we can look with this an example. So this is a patient who presented to us with a cerebral palsy and with right-sided hemiplegia. As we can see, he can walk easily with an equinus gait. He does not require any support while railing, at least in 1 or 2 flight of stairs. He had ability to run and jump, but he has decreased balance. So he will majorly fall into level 1, maybe pushing a few gray area in level 2. So we examined him, we found him that is he has grade 4 contracture, which needs a surgical correction. We corrected it by doing a Z-plasty. So the correction is achieved. After 6 weeks of casting, he underwent a rehab. But at 3 months, we can see that he can walk with a foot flat. There is no equinus. And this is, we gave him AFO. But his GMFCS did not change much. GMFCS still remains the same because he still has decreased speed and decreased balance while walking. But if the same thing would have been measured on GMFM, that is gross motor functional measurement, which has these 13 domains. So each is scored 0, 1, 2, 3. The total score will come out to be 39. So in this, before intervention, his score is approximately 28. And if you take a percentage of it, that is 28 divided by 39, it comes out to be 71%. But after intervention, it improved to 37 and the percentage comes out to be 94%. So this clearly shows a very significant change, whereas GMFCS does not change much. So for interventions in cerebral palsy, if we wish to track the intervention, GMFCS, GMFM is a better. The only thing is it is a very time-taking process. It takes at least 30 minutes. So that is the problem with this. Now, functional ambulation category, this is used for patients with stroke and multiple sclerosis. It is a score of 0 to 5, where 0 is non-functional ambulator, level 1 and 2 is ambulator dependent on physical assistance, level 4 and 5 is independent ambulator. So this functional ambulation category is also found to have a good inter-rater reliability as well as good test-retest reliability. Now, scales for assessment of TBI. This I have mentioned separately because the TBI survivors are left with emotional, psychological, physical, cognitive, and psychosocial problems. So they have a lot of problems and lot of scales are there to assess it. The most commonly used is Glasgow Coma Scale. We know like the score is between 3 to 15, dividing it into mild, moderate, and severe TBI. Then is Rancho's Lowe's Amigos level of cognitive functioning, which take care only of a cognitive functioning. It has level 1 to level 8, where level 1 is no response and level 8 is purposeful and appropriate. So since because TBI has so many domains, the other outcome measure which came to incorporate the previous one is disability rating scale. It has 4 domains, that is arousability, awareness, responsibility. Then it has cognitive abilities for self-care, which includes feeding, toileting, and grooming. Then dependence on other and psychosocial adaptability. Now for arousability, awareness, and responsivity, it has further 3 subdomains, that is ABC, that is eye opening, communication ability, and motor response. So score comes out of this. Then this is cognitive ability for self-care, not the motor response. So it is same for feeding, toileting, and grooming. So the 0 is complete is in disability rating scale. The lower the score, the better the person is. Complete is continuously shows awareness that he knows how to feed and can convey unambiguous information that he knows when this activity should occur. None is shows virtually no awareness at any time that he knows how to feed and cannot convey information by signs, sounds, or activity that he knows when the activity should occur. Then there is a level of functioning from 0, completely independent, to totally dependent. Then employability, which is a psychosocial adaptability from not restricted to not employable. Not restricted is can compete in open market for a relatively wide range of jobs, whereas not employable is completely unemployed because of the extreme psychosocial limitations. The level of disability, so this is basically a 30-point scale with score ranging from 0 to 29, where 0 is no disability and 25 to 29 is extreme vegetative state. So following this, there is a Glasgow outcome scale, and an additional version of this is Glasgow outcome scale extended. So which has following subheads, that is, if the patient is died, it's given 1, and upper good recovery is 8. In this upper sphere disability, that is level 4, is important because it has been found that all those patients who has a Glasgow outcome scale extended 4, these patients can stay at home for 8 hours unsupervised, and this gives time to the caregiver to do his livelihood. So for all the patients with disability, it's important that the caregiver should be able to earn money so that he can take care. So how these can be used, we'll see one example. So this is a study on traumatic brain injury patient, which was done in USA in 18 level 1 trauma center known as TRACK TBI study, that is transforming knowledge and transforming research and clinical knowledge in TBI. So they took patients of moderate and severe TBI, and they took an outcome measure as GOSC, that is Glasgow Outcome Extended Scale, more than 4. So it was considered to be those patients who can stay independent for 8 hours at least. So at 2 weeks, only 12% of the patient had GOC equal to or more than 4, which improved to almost 50% at 6 months following rehabilitation. So what it shows is that almost 50% of the patient with moderate with severe TBI improved to GOC4 after 6 months. Then coming to patients with moderate TBI, at 2 weeks, only 41% of the patients had Glasgow Outcome Extended Scale more than or equal to 4, which improved to 71% at 6 months, at almost 75% at 1 year. They also studied this population in terms of disability rating scale in patients with severe and moderate TBI. As you can see, initially this color represents none. Both in severe and moderate TBI, initially this occupied a very small part of the column, but as the time passed and the continued rehabilitation, this part kept on expanding, and this part, which was extreme vegetative and vegetative state, kept collapsing. So there was an improvement as the time passed with the ongoing rehabilitation, which justifies and substantiates the role of rehabilitation in patients with traumatic brain injury. So are there any drawbacks for outcome measures? Lot of outcome measures may capture differences in functioning before and after rehab intervention, but it is not necessary that they may be clinically relevant. The difference at times might be small enough to go unappreciated by patient or their caregivers. On occasion, even if the difference might be appreciable, it may not be relevant to the functioning of individual. For example, from a total paretic limb to flicker movement. And one more example I will show. Also, no scale or outcome measure can fully capture the complete range of hand functions. Also, every individual is a unique in way she uses his or her hand, and even complete recovery to motor power may not render the hand useful to the patient. Cognitive and communication problem exacerbate the complexity of data capture due to limited nature of patient feedback. Conditions like unilateral neglect make the process even more restrictive. So, this is a patient of a stroke who, after a rehabilitation, attained good power in the lower limb as well as upper limb. As you can see on testing, hamstring power is almost 5 by 5. So his hip extension, the quadriceps also had a power 5 by 5. But this is how he walks. So functional ambulation category 1 or 2. He requires total contact throughout the gait. The answer lies in the area of the brain involved. So he had a PCA stroke involving the pons, medulla and cerebellum. So there is no coordination. So even with the full recovery of motor power, he could not do any ADL or he could not walk. So the outcome measures has to be used judiciously. Now, outcome measures and goal setting. Goal setting is hallmark of rehabilitation work, and goal setting skills are deemed desirable in the field's practice. So for this, a goal attainment scale was proposed by Christian Sherman in 1968. Outcome goal setting, as told by Zakaria sir, it has to be SMART. So the goal attainment scale is from -2 to +2, where -2 is much less than expected, -1 is somewhat less expected, 0 is as expected, 1 is more than expected, 2 is far more than expected. So for a patients with knee flexion deformity in cerebral palsy, as we know that knee flexion deformity can either occur due to hamstring spasticity or reduce power of quadriceps or increase power of hamstring or both of them. So if we plan a hamstring lengthening, as expected could be that we are able to achieve extension during the stance. More than expected is we are able to have some voluntary motor control in quadriceps, and far more than expected is after the intervention, patient does not require a bracing and he has attained a full control over the knee extension. So the conclusion is quality care in rehabilitation is increasingly being demanded by all the stakeholders, that is rehabilitation professionals, patients, caregivers and third-party stakeholders. The formal process to document and improve quality and develop a culture of continuous quality improvement in the healthcare is increasingly in demand. Use of standardized tools to track and measure outcome help project the importance of specialty among peers, hospital administrator and policymakers. Increasing pay for quality is being promoted by patient advocates and insurance payer. Hence, rehabilitation professional needs to address this development proactively. Take-home message is knowledge and skill in this area is as crucial as acquiring proficiency in clinical skills during residency, training and beyond. So one small line, during my residency, so we always used to celebrate कि आज मैंने TL किया, HSL किया. We never celebrated कि मैंने किसी का GMF लिया या किसी का GMFCS लिया या किसी का SCIM लिया. So these skills are as important as achieving the clinical skills. Thank you.
So unfortunately, we are not really seeing much questions or discussion from PG trainees. This is your program. And you are the most important people here. And there are faculty available here. The people are doing the sessions. They are ready to answer your questions, ready to have discussion. But it needs to come from you, unfortunately. There's no point in actually sitting and listening. The learning effect is only 10%. 90% is discussion and seeing things and talking to people. Lectures provide you 10% of the learning. So please ask questions, please discuss. Any question, we don't have a problem. Nobody is going to jump on you if you ask a stupid question. I'm not saying that you ask stupid questions, but please make sure that you ask questions. Secondly, uh, I've seen a lot of people writing, a lot of people taking pictures. Everything is available. The videos are uploaded as we speak. All the morning sessions videos are available in Vibodha Foundation YouTube channel. So all the videos will be uploaded. So please don't take pictures. Please don't write. You could concentrate on the talk, ask questions. And the faculty is here to actually discuss things. And we kindly request faculty not to ask questions. The questions are all only for PG trainees. But all the faculty can support answering, providing more details. So please ask questions, please have some discussion. This is your program. This is a workshop like thing. This is not a conference. Okay?
We ask them.
That is, if this doesn't work, next time they will be asking questions. You know, you don't want that, no?
Maybe the location change also is helpful. Yeah. Okay, go back. I think that will be better.
So we are not seeing many questions. We are not seeing, in fact, we are not seeing any questions. So it's very important that you ask questions, you provide feedback to these presentations.